Good morning. It's good to see everybody virtually again today, and welcome to our 16th of our town hall series that we've been doing throughout this COVID pandemic. I want to thank Jeremy and Caroline Finkelstein, George and Catherine Masterson, and all of the membership of the Society for Leading Medicine for sponsoring this, for supporting us in everything you do. So thank you very much. You know, I think I owe everybody an apology because I was the one who made the decision, hey, let's take July off. Things won't be that crazy and we'll just come back, and in the fall maybe things will continue to be a little better and we'll do some non-COVID things in addition to COVID. But obviously we've had quite a 1 month period over the last month. Today, we're going to be therefore talking about almost nothing but COVID. We've actually had a record number of questions come in from all of you because, of course, we're all trying to get our arms around this and understand what's going on. Dr. Saussman is on a much-deserved vacation time right now, so he's not joining us today, but we have Dr. Ashley Drews, who heads up epidemiology across all of Houston Methodist, and who you all know very well because she has oftentimes been behind the scenes answering your questions, and so we're glad Dr. Drews is here with us. We also have, therefore, Dr. David Bernard behind the scenes answering your questions in the chat. So by all means, let's make Dr. Bernard's fingers ache by the end of today with lots of great questions. So please keep them coming to him during that time. And so with that, I want to also kind of warn everybody with all the questions we got. We're probably going to go a little long today. We'll finish our presentations well before, I think, the hour and a half, but to get to your questions will probably take a little longer than that. So just if you're planning your time, or if you don't really necessarily want to see all the questions, we're going to try and get a lot of those covered, at least in the content of our presentations. So with that, before I get to COVID, I do want to talk about one thing, and that's U.S. News and World Report for Houston Methodist. This was our best year we've ever had. Now, to put this in perspective, 4,750 hospitals exist in the United States and are evaluated through U.S. News and World Report. Only 20 of those ultimately make their honor roll, which we are on this year at number 16, which is the highest we've ever been. And only one of those, of course, can be number one in Texas. This is our third year in a row as an honor roll hospital. This is our fourth time in the last 6 years. So the two in between there, we were kind of number 23, 24, just missing it. And we've also made it one time before. So this is now 5 times that we've been on the honor roll. I'm very pleased with that, very proud of our teams and what they've accomplished. And you see here then the breadth of expertise at Houston Methodist. And this is really, I think, the story of this institution. We make virtually every specialty, all of the ones that are data-driven and not just based on reputation, with the exception of one. If those of you who are astute will look at this and say, well, weren't you on 11 last year? And that is correct. However, there were 12 data-driven specialties, and for whatever reason, U.S. News decided to take nephrology off of that. So it doesn't actually exist. So it dropped off for us, and then we had one trade out. And so we have 10 out of 11 of those data-driven specialties on here, and very, very proud of that. And what I've always said is it's not about these rankings, it's about the fundamentals, unparalleled safety, quality, service, and innovation, which then drives consistency. And so what you see on this chart is you see that top 20, you see Houston Methodist there at number 16. You also see CMS, which is Centers for Medicare and Medicaid Services, which ranks hospitals based on quality metrics on a 5-star scale, and those institutions which are 5 stars. You see Leapfrog, which is a group of employers which ranks hospitals based on safety twice a year, and those hospitals highlighted, they get an A. And then you see Vizient, which, as many of you know, is actually the one I pay the most attention to because it's very data-driven. It's a member-owned consortium of all of these institutions. We share data in a very standardized way. It's all about outcomes. It's not about reputation and some other things like that. Now, there's a little asterisk there because Vizient, with COVID, decided not to allow any of us to be public about our rankings or other people's rankings in the midst of the pandemic. So this is 2 years ago's data. I can tell you we were on it last year, and I can tell you we will be on it again this year and do very well across the system. But the other fourth category may be slightly off since then because I just don't have visibility into that. But you can see in this, with those metrics, only 3 institutions really with that level of consistency. And so I'm very proud of the team and what they've achieved. So with that, I'm going to move on now to COVID. And honestly, it's that very same kind of consistency and focus that has served this institution, I think the citizens of Houston, very well throughout the COVID pandemic. So last time we talked was on June 9th. this is what the curve looked like. It looked pretty darn good, and it was exactly what we had predicted. We got enough people vaccinated, enough people with natural immunity. We had an alpha variant, and we knew we needed to kind of approach 70% to be herd immunity. If you looked at those two numbers, you were probably somewhere in that range. And we had a controllable situation. But unfortunately, because of the Delta variant, which we'll talk about, everything began to change a while after this still, but everything began to change. So this is what that same curve looks like today. Now what you see is really towards right at the end of June and the first beginning parts of July, it was creeping up a little bit. And as we were watching our own genomic data, we were seeing the Delta variant was really at that point starting to hit some critical mass in the community. And then we saw an inflection point right about the 15th, 16th or so of July, and are seeing as steep an uptick as we have seen really at any time. This looks a lot more like last summer than it did this winter, which actually was pretty, kind of gradually, continually increasing and then spiking towards the end. Area under that curve was much higher, so way more people in that third surge in the winter than in the second surge. The question here, of course, will be how high will this go and how quickly will it come down when it does. But right now, this has been a very significant challenge. You see we're all the way up at 650. We started the month of July at 87, so that's the kind of increase we've seen since then. During the day, we go higher than that. Usually, I can tell you this morning at 7 a.m. we had 680 patients in-house. Our all-time record 7 p.m. close was 730. During the day we'd get into the 770, 780 range. So we are rapidly approaching that as we speak. This is the testing data. The blue bars are the number of people testing positive. So we're still not seeing quite as many tests positive, at least through Houston Methodist, as we did in the last surge, but it's certainly driving plenty of hospitalizations, and you can see the positivity rate has shot up. That's the orange line, almost to the levels we've seen before. It hasn't appeared to stop yet as we move forward, and so that's been a big challenge. So, I'm going to structure this talk around a few questions y'all want to ask. This is one I hear a lot. It's one I ask a lot. Life was almost normal. It felt so good. What the bleep happened? And that's a 4-letter word, and it's not the nicer of the 2 4-letter words, I will tell you right now. And that's certainly the way I feel, the way people around this institution feel as well. So let's go through some of what did happen. This is the Delta variant. The cold, hard reality is the Delta variant, which came about in India in an essentially unvaccinated country. So there was just lots and lots of spread, lots and lots of mutation, and eventually a mutation that took over and then began to spread through the world because it is so highly transmissible that it outcompetes all other variants, much in the way the Alpha variant, or what was called the UK variant before, outcompeted the previous variants. The difference with it was while it was more infectious, it was not nearly as infectious as the Delta variant. We'll talk about that in a couple of minutes. And so this is what Delta variant has looked like. This is on the left, Houston Methodist's experience of measuring the Delta variant. You can see the days since April 15th is the way it counts, so you can figure out where that is. But if you look at where that was, it was really inflecting kind of towards the end of June into July and then shooting up in July. And as this is so dramatically transmissible, this is the fundamental reason we are experiencing what we are experiencing. That is dramatically exacerbated by low vaccination rates, and I'll show you some more data around that. And I'll show you data around who's in-house, the fact that the vast majority of people are unvaccinated individuals. The bottom line is, I think we would have had a surge no matter what with Delta, because it is so highly infectious. But that surge in terms of numbers of infection, and most certainly in terms of hospitalizations and deaths, would have been so dramatically different that we would have been sitting there saying, yeah, this is kind of routine COVID times, higher than usual, but very manageable across our hospital system, and life would have been able to go on much more normally, even in the midst of a surge like that. And that brings me to the third point, which is, until very recently, little to no community mitigation. We pretty much moved on. By June, everything was so normal. It felt so good. It was an appropriate response at the time, but what we have shown ourselves so bad at doing is is then as a society recognizing when we need to go back to those behaviors. And of course that's been politicized, and there's lots of challenges around that. And to this day, with the level of surge we have, we're nowhere near the mitigation activities we had in place in the winter to get that in control. Whoops, sorry, I went backwards. So why is this so infectious, or how infectious is this? This chart is a little different one than I've shown you before, but what this is different infections and kind of the upper end estimate of their infectivity, the R. Remember how many people you infect. So the really bad flu pandemic of 1918, most numbers I see is about 1.8. They rounded to 2 here at maybe the upper end of that. The original coronavirus strains at the upper end were about 3. I think they might have actually been a hair lower than that. This one is as high as 7 on the upper end, certainly somewhere in the 6 to 7 range. Remember, these are exponential functions, right? If I tell 2 friends and they tell 2 friends and so on, or I tell 6 friends and they tell 6 friends and so on, those are very different functions. Now that's not what we see in real world, because of course we are mitigating and we have a whole bunch of people vaccinated and we have a whole bunch of people with natural infection, so we don't get to a real world R that high, thank goodness, or it would be absolutely horrendous at this point. But nonetheless, it basically has been what has pushed this pressure. You notice it approaches, not quite at, and the CDC overstated this a little bit, but it approaches the chickenpox virus, which of course back in the days, for those of us who remember, before there was much chickenpox vaccination, you stick a bunch of kids in a classroom and somebody has chickenpox and the whole classroom would have chickenpox. And so this is highly, highly transmissible. Clearly the hot spots are happening mostly in the South. There's actually a hot spot in a part of Oregon as well, mostly in under-vaccinated areas as compared with other parts of the United States when you look at the data. And in fact, this is a Wall Street Journal analysis. So let me walk you through this. On the left, what you see is states. And from left to right, basically, you're seeing how high a percentage of vaccination there is. And then, on the y-axis going up is how bad things are in the state. And while it's not a perfect correlation, pretty much the low vaccinated are in the upper left quadrant, which is, bad. And the highly vaccinated are much better in that right quadrant. It's not everybody. There's some smattering on the bottom, but that's a strong, strong correlation if you do the statistics on that. And then in the upper right, you see a county by county analysis. And so the least vaccinated counties, I think it's the bottom quartile or quintile of counties, and you can see how the infections and deaths have shot up versus the most vaccinated counties. And then the final thing you see is the age distribution. So that left-hand one, in the yellow, you're seeing younger people in the winter surge, and then in the right one, you see that same age breakdown in this surge. This is now a younger person's issue, mainly because the younger people are much, much less vaccinated than the older people. And so now you see nationwide, you get past 50, in the younger people there as you look at that. Interestingly, kind of looked at this ourselves. This is something we pulled together. One of the listservs I'm on with a bunch of hospital CEOs around the country, everybody set out, hey, how many beds do you have? How many beds are filled with COVID? I blinded who it is, but I put what state they're in each of these cases. So the blue bars, or in our case, the orange bar, is what percentage of your beds, this is a few days ago, were filled with COVID patients. And then the green line, and they are aligned by that green line, that green line is the percentage of the state's vaccination rates. And so absolute dramatic trend there. It's not a perfect correlation, obviously some in the middle there, or the middle bad part, but like Houston and other parts of Texas like Florida are pretty high, but really everybody towards the right is way higher than everybody towards the left. I mean, I sit there and I get notes from people, yeah, we have 1,000 beds and we have 6 patients in a COVID. And those are the kinds of notes I'm getting, and I'm sending back saying, yeah, we have 2,300 beds and we have 650. And that's what we are unfortunately dealing with right now as a state. So, is this really a pandemic of the unvaccinated? And what do I hear about breakthrough infections? And people, kind of the subtext is, well, if there's breakthrough infections, why would I get vaccinated? Let me be really clear. You want to be vaccinated even more now than you did before. So let me show you some of the data. So last week, CETRAC, which is the Regional Advisory Council, kind of handles disaster management around hospitals, we all work together, all the hospitals in the region. You can see the geography there in the yellow-blue blue, purple, green. Basically a snapshot, 91% of patients across all of these hospitals in this region were unvaccinated individuals. Okay, so that means we could have a tenth of the people in hospital that we do now, minus maybe a few breakthrough infections in that group. But remember, the other 9% wouldn't be getting infected if everyone around them wasn't sick. And so we could have a tiny fraction of people in hospital right now that we do. When we look at this at Houston Methodist, our numbers are a little higher in the vaccinated group. About 17% are vaccinated, about 83% are unvaccinated. You know, why is that? Well, we take care of a very sick population. We have all the transplant patients. We have a lot of the cancer patients. We have a very strong Medicare population. In that region's a bunch of community hospitals and others. So I'm not surprised by those numbers. And the bottom line is the people in that 17% generally are the people we should be all together working hard to protect, because they are obviously less able to protect themselves. So let me show you some pretty interesting breakdowns. So on the left here, you see the age distribution, and then the axis is the same on both. So the size of the bar is also consistent across both graphs. For on the left, you see people who are unvaccinated and have required admission to Houston Methodist really since the beginning of July when we started seeing the Delta surge. And to the right, you see where we have seen vaccinated individuals. The first thing you see is those are dramatically different distributions. First off, on the left, much taller bars and much left shifted. Young people, the tallest bar is in some of the youngest people out there. On the right, what you see is far lower numbers, but what you see is it's obviously skewed towards older groups of individuals. In fact, the average age is almost 69 in the vaccinated individuals, is about 53 in the unvaccinated individuals. That is a marked difference. Dramatic evidence that vaccines work, but also raising some questions about who are they not working in or not working as well in? Because remember, look at the small size of those bars on the right. We don't have lots of old people getting infected, thankfully, right now, because they're at highest risk of bad outcomes. Now, very interestingly, you see a several point difference in the percentage of people who are unvaccinated versus the percentage of people who are vaccinated who require ICU care. Keep in mind that the people on the left are average age of 53, the people on the right are average age of 69. So just based on age alone, I would have expected to see markedly more ICU utilization in the group on the right. So the good news is even those who are vaccinated, some pretty strong, compelling evidence that people are having milder illness. So even if it is a breakthrough that's bad enough to require hospitalization, people are having a milder case on average, okay? That doesn't mean every single individual, but on average as we look at that. So if you look at the national data of breakdown of who has gotten vaccinated so far, you see the curve on the left of at least one dose, or the curve on the curve on the left of at least one dose, the curve on the right of people who have completed vaccination. You can actually see the data table on the above. And so keep in mind, one of the reasons we see more older people as breakthroughs is because way more older people have vaccines, so your denominator is far larger. But I think it's more than that, and I did some math on this. This is back of the envelope. It is not perfect, lots of assumptions, but it is very directionally, and I'm fairly certain we're pretty accurate in this. If you take those same age bands we were looking at in those infection rates a couple slides ago, and then you compare that with the vaccination rates, and then you look at efficacy, because you look at kind of how much of the population is in the vaccinated group versus the unvaccinated group. When you get to the younger ages, to prevent hospitalizations, even in Delta, we're looking at 98, 99, 97% kinds of efficacy. What you do see, though, as you tail off into the older age groups in the 70s and the 80s, is now you're getting into probably the 80s as efficacy. So let's talk about, why is that? Because there are several possible reasons for why we may be seeing that. First, and Dr. Drews will go into this probably in a little more detail in her slide, we know for a fact with really any vaccine we give, and this is data specifically around COVID vaccines, that older people have less of an immune response than young people. That's just the nature. All of our immune systems age just like everything else does as we get older. And so some of this may simply be that older people just don't have as robust an immune response at baseline, and they're never better protected than a 20-year-old. So there may be a little of that occurring for sure. Another in this whole scheme is that unfortunately we are seeing the vaccines are probably not quite as effective for Delta. But let me be really clear, they're really dramatically effective against what really matters. And so here what you see is a couple of different studies in different countries. And in blue you see the previous alpha, in red you see the efficacy around Delta. They don't all have the same 3 bands, but they give you the same idea of, infections versus hospitalizations, etc. And what you see is not too dramatic a difference in some of the earlier studies that you saw on the left, but the country of Israel, which has been the farthest along, while you're still to the far right seeing very, very, very good prevention against hospitalization, although not quite as good, you're seeing far less protection potentially in that study against infection. Now those then are by definition mild infections mostly because they don't result in that. So obviously if we can prevent hospitalization and death, at the end of the day, while we're not thrilled about people getting infected, that's much more like many other respiratory viruses that go around in the community that we all pass around and either have natural or vaccine immunity to. This is a more recent analysis coming out of England. They have these different sort of groupings they looked at of kind of time periods. And so they were on to their 12th and 13 of those. And if you look at the column there, you'll see now you start seeing efficacy against infection rates, and this isn't a below 65 population, in the 60s, 70s, something in that range. So some suggestion there that the Israel experience may indeed be correct, that we are going to see more breakthrough mild infections, but again, not necessarily seeing the same dramatic amounts of hospitalizations for the average person. But of course, if you infect everybody, you see the surge like we are seeing right now. This is another study that came out. I think it may be a flawed study. It's preprint right now, but it's still interesting to look at. And this is the question about waning immunity. Is immunity getting worse over time? So they looked at this in the UK. They basically had about 30,000, 33,000, something like that, individuals who came to get a PCR test for COVID after they had previously been vaccinated. So for some reason, screening, I'm going on a trip, my child, maybe is infected and I want to make sure I don't have it, or I'm having symptoms. It didn't differentiate between all of those at a market level, but they looked at those individuals and said, okay, what percentage of those individuals were positive? And they broke them up into half of the people who were less than 146 days from when they got a shot, and half of the people were more than 146. In other words, that was the middle point where you could divide the population in half. And what they saw at all age groups, the percentage of positive in the people past 146 days was higher. Now you're still talking 2-3%. You're not talking massive positivity rates. Now I put some cautions in the right, and actually much to my surprise, they don't even talk about a couple of these in the paper, and this paper is not going to get approved in its current fashion, in my belief, to get published, but nonetheless it's useful to talk about, because remember, they measured this from May 15th, I think it is, to July 26th, right as Delta was surging, which had more breakthrough infections, and they even comment that most of their infections were happening in the last couple of weeks. So if that distribution was different in the groups, you may just be picking up the fact that it was a backloaded group of people who got infected, a higher prevalence situation. So we just don't know, but there's at least some suggestion in this data. And in fact, if you look at titer studies and a lot of other things, we know there's been some waning in those titer studies. I can tell you from all of our experience of testing some of our patients, we're seeing titers that are starting to get lower with some of the older people. And so you've seen some countries and an increasing number of countries decide to start administering boosters. I don't even pay attention to Russia because their vaccine really isn't a very good vaccine to begin with. So I kind of pay attention to the right side of that graph. Israel decided to start giving boosters to everybody 60 and up about a week ago who is 5 months or more since a vaccine. It's actually pretty similar to the data you just saw. That wasn't, I don't believe, driven from that study, but just seeing some waning immunity. The UK, Germany, France are all going to start this within the month. And so we are very hopeful the FDA will start moving more quickly on this. It does look like today, maybe tomorrow, but probably today, they will authorize third vaccine doses for immunocompromised people. How they will exactly define that, how they will restrict us is uncertain. I just, before here, was doing a KTRK interview, and they asked me, well, what do you think about that? And I said, I have two thoughts. I said, hallelujah, and what took you so long? We've seen for months, really from the beginning, that our transplant patients weren't mounting big immune responses. But under an EUA, it's like we have handcuffs on. You can use it exactly the way the EUA states. We cannot deviate from that. If we get full FDA approval, we can use off-label, make our own clinical decisions, which is what our clinicians should be able to do, and our institution be able to put protocols in place. So we applaud them for this. We're really glad they're doing this, but we're really urging them to get moving on the question of booster doses for the rest of the population. Where does that go? Where does that start? Is it a time period? Is it an age group, etc.? On the good news side, this was a draft, from the other day, but you can see below that, this is August 13th, tomorrow. The ACIP, which is the committee that ultimately makes these recommendations to the FDA, is actually meeting on this very topic. So I'm cautiously optimistic we will see some booster guidance at a broader level, maybe within a month or so. And I can tell you we will very aggressively be in the booster business when that comes time. And so stay tuned. But we already are gearing up for that, ramping up for that, assuming that that happens kind of towards the end of the month. And we will be ready to do that. Because the reality right now is people are taking matters into their own hands. This was in the press, I think, yesterday. The CDC now estimates at least 1 million people, and my guess is it's more than that in the United States, have already taken matters in their own hands and gotten another booster. Because if you got your 2 at Methodist, you can't come back to Methodist. Our hands are tied. We know you got them. You're in our database. If you go to the county site, they're probably not even checking the state database, and people are fibbing, obviously, and saying, nope, I haven't gotten it, or I only got 1, or whatever, and they're going in and getting those third doses. The people I've seen who've done that, where I've seen some antibodies measured, they're having dramatic antibody responses, which is consistent with what all the papers show, which Dr. Drews will share with you later. Okay, so the $100,000 question, how bad will this get and where is this going? So let me show you some data. This is the UK, and the UK got slammed by this variant, Delta. They didn't have all the deaths and hospitalizations, thankfully, but it was a very steep peak. It came back very steeply. Now it's leveled off, because remember, right in the middle of this, they also opened up their society, probably to a level we've been open at for several months. So one difference for them is they're much more vaccinated than we are, and they had a lot of societal protections in place for a lot of that curve. We're not nearly as vaccinated because they're far ahead of the U.S., and we in Houston are far behind the U.S., and we don't nearly have those protections in place. With those caveats in place, that point from the inflection point to the surge was about 4 or 5 weeks. So then if you look at the initiating country where this surge happened, in India, which was a very unvaccinated country, and you look at that inflection point, it's very steep down, and it was about a 4 to 5 week period from the inflection point to the peak. So we're looking at that, hoping that we see similar curves here. So what do we know so far? This is a curve by region across the entire pandemic of the United States. We're in the light blue, I think it is, as the South, and they call out, because it's been so bad there, they call out Louisiana in the dashed dark black or blue line, and you can see during pretty much all of the surges, they're right up there at the worst of anybody, and they are way, way up this surge. If you actually zoom in on the latter part of the surge and look at the graph, Louisiana is starting to crest, and actually you look at the light blue for the South, it may be starting to crest. Now that's the South as a whole. That means some are going up, some are going down, but we may be seeing some early evidence of that. So when I look at that kind of 4 week to 5 week surge period, or after the inflection point for us, that puts us somewhere between August 14th and 21st. So we got another week to 2 weeks of this, if, and that's hope's not a strategy, but if we are doing that's there. Now we can't count on that, so we are planning as if this keeps going up, because it is shooting up. If it does curve at that point, I'll show you some numbers in a second. Now we do have some reason for some cautious optimism. The RT, and on the left that's UT School of Public Health, on the right that's University of Texas Austin, The observed R in the greater Houston region right now has been coming down after it shot up. Now notice it shot up far higher this curve than it has before. That's why this has moved so fast, and that's a delta that layered on top of the things that hold R down is now 7 or 6, whatever it ends up being, versus 3. And so we've seen that spike. It's coming down, but remember, it's still well above 1. As long as it's above 1, it's spreading. We need it to come back down below 1. But some early cautious optimism that maybe either it's burning itself out or we are doing some more things on a mitigation perspective as a community. When I look at our data, I don't see the cause for optimism yet. This is the 7-day average admissions per day. So you get started in mid-June, you can see kind of what it was bubbling along in May and June. In fact, even bubbled along through part of July at a slightly higher rate, and then it inflected, and that of course directly relates to that curve you saw. A couple weeks ago, we had a little minor flattening out for a couple days, but it started right back up again. Yesterday, so Monday or Tuesday to Wednesday nights, as we measure this, it stayed flat. What that means is a week ago we had 93 people and yesterday we had 93 people, so they just replaced each other. It's still 93 people, and it's running at an average, as you see, about 97. The highest average we ever had in the winter was 106, and so we are getting very close to those record levels. If this goes up again, we will most definitely surpass that. And so when we do our own internal modeling, it can look pretty ugly. And let me tell you, modeling is really hard this time around. We don't have the, on July 3rd, the governor put a mask mandate in kind of date that you can say everything changed today, and we can actually put in some models. So when we look at the median model, that's that line that just keeps going up. It's really ugly. If we look at the model that says, hey, we're seeing a little signal in the R and we think it's starting to come down, and we plug that in, that's the green line, which is going to put us well above the last record. As I said, at a 7 p.m. record, it was 730 patients. So while I don't have a crystal ball, I think it's rather inevitable we will be at record levels during this curve. So what's everybody else saying about this? On the left, you see UT School of Public Health. On the right, you see UT Austin, the COVID modeling project. UT School of Public Health doesn't give you a long projection, it's a short projection, and it's basically 50-50 over the next couple of weeks. It keeps going up or going down. If you look at the error bands, UT Austin, you're gonna have to look at this really closely, but there's a lot of, like a whole myriad of light gray lines, some of which keep going up, some of which bend going down. Their kind of median model is still going up pretty ugly. If you look at the IHME, which is out of Oregon, which has been used extensively throughout this pandemic, they suggest we're within a week to 2 weeks of peak. So the information's all over the map right now, but I think best case we're a week to 2 weeks still. We need to take action today as a society to bend this curve. So how is this surge so far in terms of severity? Are we seeing the same level of death? And I'm going to tell you right now, the answer is we don't yet know. It's too soon to know a definitive answer. But let me show you some information around that. One is the UK. So the UK saw a pretty solid decoupling of infections from death, which is obviously very encouraging, although I will tell you that's not what I feel like I'm seeing in our data right now, certainly not to that degree. But they saw huge infections, not that many deaths. Now remember, deaths are a little bit of a lagging indicator. This is the trends, or these are the trends in the state of Texas. In the upper left, you see the number of cases. On the upper right, you see the number of hospitalizations. On the bottom left is testing that's happening, and on the bottom right is deaths. When you look at that and look at the numbers, and you pick a date on the upper left in terms of number of infections as we were going up in November that kind of matches where we are today, and then you look at the upper right and you say, the hospitalizations aren't that different. The testing's a little different. I think we're not quite getting as many people in to test. What you see on the bottom right is the deaths are significantly lower at this point on that uptick than they were then. But let me show you the huge caveat in that data. The lead up to the fall surge was at a very high plateau. The lead up to this surge is at a very low plateau in June. So the kind of accumulation of really sick people who were fighting for their lives and where the teams of physicians and nurses were fighting to save them just have not accumulated this time like they did last time. So this may be an artifact or a result of that. I just don't know at the present time. But what I can tell you so far, at least, we don't see the same number of deaths, but it's still significant, but not quite at that level. These are the demographics we see in Houston Methodist. Now, these are demographics for, and you'll see that in the next slide as well, for discharged individuals. So I'm going to put a couple cautions around that. But what you see in this surge on the left, significantly lower age, right? We already showed you those data. What you see on the right is very interesting across the surges. Remember, surge 1 in the spring, we saw very disproportionate impact on the African American population in Greater Houston. The Greater Houston African American population is approximately 18%, give or take a couple percent, and obviously varying quite a bit by parts of town. In the second surge, this was very, very, very disproportionately the Latinx population. The third surge actually close, not perfectly, but relatively closely mirrored racial and ethnic breakdown in the community, and this surge appears to be doing the same, actually a little overrepresentation in the white population this time versus the previous surges. And so obviously we'll keep watching those data going forward. But here's some interesting data around some of the clinical outcomes. Now, the first thing I'm going to show you before I start talking about the outcomes, because this is extraordinarily important, and that's the box on the right, upper left in red. And that box says that, look, none of these are final outcomes. These are the people who have come to our hospitals, and we know what happened to them. Most of them went home. Some of them died. We have lots of people still in hospital, and the sicker you are, the more likely you're still in hospital if you were admitted 3 weeks ago versus somebody who went home. So anytime we see a big uptick like this, the mortality is always understated early. That being said, I think this is lower than we saw in early parts of other surges, but that number that's like half of what we've seen in the other surges is not going to hold. That will come up substantially, but given the younger population, given what we're seeing so far, I do think it will end up lower, but that's still a very deadly illness. Remember, the flu, once you're admitted to the hospital, has about 2% mortality. So nonetheless, in these young people, this is still far more deadly than the flu, but you are seeing less ICU utilization, less length of stay, less mortality this time around. Again, those numbers will all come up over time. So given all this, how do we get out of this mess? Because it's a mess right now, and when you go around town, you barely know it, but let me tell you, this is a mess, and it's going to get even messier. You know, last summer, at the height of my frustration, certainly, I kind of came out with what I thought were the 5 kind of difficult lessons we had to recognize, and they're the same today. The first is science is the way out of this. And the vaccines are the way out of this. We would not be in this place. From a hospital perspective, we focus on our sacred and, which is we've got to care for everybody, and you will see us steadfastly work towards that. The third thing was really a call for our leaders, our political leaders and others, to recognize their and we're in the midst of the exact same situation. You got to control COVID, you got to optimize the economy, and you've got to keep our kids safe but get them well educated. Unfortunately, time and time again, our collective political system doesn't know the word and. It's all about the word or, and that is one of the reasons we are in the challenges we are. We have to make social sacrifices to get this in control. It's just like last time, and masks must be worn everywhere. If we're seeing some breakthrough infections, if you can't tell who's who, and most importantly, if the people who don't want to get vaccinated are the same people who don't want to wear a mask, unless you make everybody wear a mask, you'll never get them to wear a mask. I mean, it's just a cold, hard fact that some of us who are vaccinated have to make that small sacrifice to get the people who aren't unvaccinated to do the right thing to protect us, to protect each other, and to protect very vulnerable people. The vaccines have saved countless lives. Now, this, of course, is a curve earlier prior to Delta arriving, but it's going to be even more so because now Delta is surging, and would have been surging so massively out of control if we didn't have vaccines. But you're talking well over 250,000 lives in the United States have been saved, over 1.25 million hospitalizations projected to have been saved. Just imagine if we didn't have the vaccines and we were dealing with an R of 6 to 7 right now, I wouldn't be seeing 6 case 80 in our hospital right now, we'd be basically crumbling at this point because it would have just shot so far out of control. So, a couple key points I want to make around that. This applies to you even if you've been infected. I know there's a lot of discussion out there. This is the best study I have seen. They took a look at previously infected individuals across the state of Kentucky and then said, for those who were vaccinated, who were previously infected, or those who were previously infected and chose not to be vaccinated, what happens? 2.34 times as many people who did not get vaccinated got reinfected as who had been vaccinated. The vaccines are better in every immunological study, every titer study, which is level of antibodies, every study out there, they are stronger and better, at least with one dose, than native infection. Now there's some noise out there because like science is real-time messy, as I said before, there are studies out there that don't always point in this same direction. One that gets cited oftentimes is the Cleveland Clinic. And if I'm being completely honest, which I always will be, we don't 100% know the answer to this question, but I think the science strongly points to the fact that people who've been infected need to get vaccinated. What the Cleveland Clinic did was they said, here's all our employees, and now let's look at where we had subsequent reinfections. And I put together this box. So you have vaccinated and unvaccinated individuals, and then you have people who have had a previous infection and people who haven't had a previous infection. And what they did was they measured that and they said, hey, the only group we're seeing a steady increase of infections is the unvaccinated, previously uninfected. But I'm going to point out some real limitations to this study. Whether they kill the study or not, I don't know, but they are real limitations. And one is they weren't doing surveillance testing. Okay, so if you're not doing surveillance testing and you're not picking up some of the low-level, less symptomatic infections, which we see in our surveillance testing, then basically the two boxes on the top are understated and the two boxes on the bottom are overstated. Now, between the green and the blue, that's irrelevant because both of those were almost zero, so it doesn't really matter which box somebody's in. Between the red and the orange, what that means is there's a bunch of people who probably were previously infected, got infected again, but they were asymptomatic and they didn't do surveillance, that are in that upper right box. So while I'll bet that upper right box is a better place to be in than the bottom right box because there is partial immunity from being infected before, I don't believe that they accurately achieved this. And again, this is preprint right now. It's not been peer reviewed. I think that will get caught on peer review and they'll probably be made to go back and take a look at some of those kinds of issues. Another very important point, you've heard this time and time again from us, pregnant women should get vaccinated. The data wasn't perfect in terms of safety, not because it wasn't safe, but because they just didn't have the women in the original trials. But we in our OB-GYNs were saying every reason to do this. Women are at a higher risk during pregnancy, particularly in the latter part of pregnancy and early postpartum. Women pass antibody onto their infant if they breastfeed, which is a benefit to the infant. So recently the American College of Gynecology came out absolutely crystal clear, unequivocally, and now the CDC unequivocally saying pregnant women should be getting vaccinated. So no equivocation whatsoever on our part. If you are pregnant, you should get vaccinated. It is not relevant, frankly, that you're pregnant or not pregnant in terms of thinking about not getting vaccinated, but it's highly relevant in terms of getting vaccinated because you're higher risk than somebody the same age who's not pregnant at that point in time, and your infant is at risk as well. So at the end of the day, the answer is vaccines, but this is what we are facing as a society, and we are unfortunately feeling like we are having to drag along such a large part of our population. And look, I'm not saying these are bad people. There's a cadre of very bad anti-vax people, but these are people who aren't listening to the right sources, who are being, bombarded with misinformation, who have human natural tendencies to be conservative and in kind of what they perceive as risk. We as human beings, sociological study after study after study for decades shows that we're not good at assessing and responding to longer term risk. We're really good at somehow perceiving short term risk, right? When I don't like heights. When I walk up to the edge of a big glass building, I feel my knees wobble. My body's fight or flight response is saying immediate risk, kind of danger Will Robinson kind of thing, right? my body doesn't have that kind of response to something that might happen to me down the road. I deal with that as a primary care physician constantly, whether that's obesity or whether that's alcohol or whether it's drugs or whether it's tobacco, et cetera, or lack of exercise, all these different risks we don't perceive. The risk from COVID is so far and above the risk of the vaccines, it's not, I mean, it's ridiculous. They're not even on the same planet as we look at that. Now, the good news, the silver lining in some of this is stimulating some of the population to say, okay, now I understand a little better the risk benefit, and I perceive the risk is higher, so I'm gonna go get vaccinated. Now look where we were as a country, look where we are, but it is going up, and we're seeing the very same thing in our Houston Methodist data. If you look at the right there, all of the blue bars are first doses. So we're seeing first doses back kind of towards end of May levels. They need to be at peak levels to be able to do this. And so the irony is we collectively, society, have so much supply, it's coming out of our ears. Anybody who wants vaccine, we could get the rest of the population of Houston vaccinated in 2 weeks. Seriously. Everybody's got it. We'd put together a 24/7 because we can get the vaccine in, and we could do that. But people aren't coming to do that. We're getting creative. We did the Astros again the other night, actually vaccinated, I think 800 people, something like that at the Astros game, and continue to do activities like that. I'm very proud of what we've done around the mandate. This is June 9th, where we were. We had announced on March 31st, went into effect June 7th with a 2-week suspension, so June 21st it was fully implemented, although those people were out of the workforce as of June 7th. Very few people followed suit early on. In fact, Benefice is a small little one in Montana who later the state passed legislation and basically made this illegal, and so they had to back off. Really after that, you saw MUSC, Medical University of South Carolina. They and Houston Methodist are the only two institutions in the entire country who have completed their mandate and whose employees are safe and their patients are as safe as can be. All of the others began to follow. You saw Penn Medicine was a very important one in May, creeping along. And then what you saw was a number of things happen. One is in mid-July, you saw all of the major societies, I mean, we're talking like 50-something of these societies recommending mandatory vaccine for healthcare workers. This is what it looks like since then. This is actually page 1. These are all the institutions who have followed Houston Methodist lead, most of whom happened kind of into July as this surge is happening. This is page 2, so we're just about to do page 3. You'll see Texas Children's just announced yesterday, so they are now the 4th system in Greater Houston. We still have all of HCA, CHI St. Luke's who haven't done this, the county, MD Anderson, UT Health Science Center, UTMB, all of them are basically precluded from doing this by the governor's orders, so you won't see them follow, but I'm hopeful the others will continue following. You're seeing this across the country, and in fact, this is now about, it says health systems, they really meant hospitals. This is now about 1,500 hospitals, which is, as you saw earlier for US News, it's about 4,750, but that doesn't include a bunch of VA hospitals and others. So this is a little over 25% of hospitals around the United States. This must happen with haste for every hospital, doctor's office, dentist's office, nursing home, anything in healthcare, any institution in healthcare, any worker in healthcare should have done this long ago. They absolutely should be doing this now with the Delta surge. Let me show you some real world experience in our case, and this shows how this has fulfilled really our sacred obligation. I took a snapshot on August 9th of 2020 as we were in the midst of this massive surge. We're actually starting to be on the downslope of this massive surge. We had kind of accumulated 9 employees. Remember, once you get admitted in ICU, you may be there a long time. Again, we have 26,000 employees. At every point in the pandemic, we have tracked at a lower level because our people are more careful, but still have tracked what happens in the community as you would expect at a lower level. And so sadly, we had 12 of our employees hospitalized, 9 were in the ICU. 1 was on ECMO, and then 1 got put on ECMO that day. The person who got put on ECMO that day has been very public about that. She survived, and go to our website or go to Facebook, you can hear some amazingly compelling stories about her. The other individual, unfortunately, did not survive, and one of the other individuals did not survive. So we had 2 of our employees that were in-house at that point pass away. This year, Actually, today it's 1, but 2 days ago, or when we were doing this, it was 2 people were hospitalized. One was a pregnant individual who decided to defer. We allowed that, and I still would have made that decision given what we had at the time, but now that door needs to close because it's very clear out there. And then one individual who has a very compelling reason not to be vaccinated. I mean, has an absolute contraindication. The very kind of person who can't protect themselves, we should all be protecting. That person's still in-house, but they're both unvaccinated. Not a single vaccinated person, not a single person in ICU. That is a world of difference in a year. So not only are we protecting our patients, which was our sacred obligation, but we've fulfilled our obligation ethically as an institution to protect the people who work here and to protect each other as fellow employees. And critically importantly, we have protected our capacity to care for the community during a surge because we will have far less absenteeism. And I don't know if you've seen the stories, but one of the other hospital systems in town shut down 3 freestanding emergency rooms because they couldn't staff them, and they could staff them. They needed staff in their hospitals, and they closed down freestanding emergency rooms in the middle of a surge. This is not a position anyone wants to be in. And again, it's us and MUSC that are in this position in the entire United States because every other mandate is effective, September 1st at best. Now they've obviously made progress since then, but none of them have kind of closed the book on that. And so very proud of that. A number of countries have made this decision. You see some very large countries that have said, we mandate this across the board. Now they have nationalized healthcare systems and those are public employees, but they are making that decision across the board. Yesterday, the Greater Houston Partnership, signed by their leadership as well as signed by 4 of us as CEOs in the medical center, myself, David Callender at Memorial Hermann, Doug Lawson over at CHI St. Luke's, and Paul Klopman at Baylor, co-signed this letter urging businesses to play a more active role. The reason for this is I think the conclusion is inescapable that the only way we get this in control is to start pushing people to get vaccinated. It's not, although the headline says that in the Chronicle, it's not a sole recommendation to say all business should mandate. Let me be really clear. This is businesses should take a very active role in controlling this pandemic. That is coaxing, cajoling, incentivizing, creating hurdles for people who don't get vaccinated, making it easier and making it desirable to be vaccinated. For some, it may be a mandate, and it is mask mandates in place again in those institutions. It's work from home, it's spacing people out, it's shutting down large gatherings, all the things we need to do. Again, I urge you to read the letter. It gives you some, I think, very good information around what has to be done. Fortune magazine just had an editorial from the former CEO of Medtronic, someone I know well, urging that really all businesses should be mandating, and actually calling us out specifically in that editorial for our leadership nationally around this issue. There are many resources out there. We published in the Harvard Business Review, a group of us, the details of how we developed our vaccination policy and how we decided to do this. A lot of what we talk about there could be applied to many other things short of a mandate, right? For instance, a choice. You can mandate or you can get tested. We just saw the county court just did that that's federal court, driven by the federal judges to say, get vaccinated or you can get tested twice a week. Think about that for your company. I wouldn't pay for it if I was the company. If someone chooses not to be vaccinated, they can pay for that. That's going to quickly get people to change their mind. Think about your health plan. You will spend way more money, and we've looked at these. We have employers spending solidly 10 to 15% of what they spend, meaning that's all incremental over a normal year on employees with COVID now. Think about differentials for people who are COVID or not COVID. Obviously, work with lawyers on all this stuff, but incentivize, coax, cajole, give bonuses, figure out the things that move this needle forward. A couple months ago, there was a really good resource in the Harvard Business Review also on how employers can reduce vaccine hesitancy. So a bunch of techniques to follow to help lead your employees through the decision-making process. We cannot be in the position of calling people who've not been vaccinated bad people. They're not bad people. They're acting on bad information. They've been influenced by the wrong information. They're acting like human beings act sometimes who don't fully understand the information. We have created a society with the internet, with our political environment, where people have lost trust in many institutions, in physicians, in nurses, in hospitals, certainly in political leaders and others. And so those, particularly the hospitals, doctors, et cetera, have a lot of degree of trust. Employers have a lot of degree of goodwill and trust with their employees. Be part of this solution as we move forward. I alluded to this before. We need vaccines approved for children under 12. Unfortunately, and these kind of go in sequence, you saw the FDA going back and saying we want more information and we want to follow kids for longer, not because they were seeing signal, but because kids are younger and they said let's wait longer. Consequently, they're now saying it could be as late as midwinter. The American Academy of Pediatrics a few days ago sent a very, very strongly worded letter to the FDA saying, my words, this is ridiculous. We're in the middle of a pandemic. We're in the middle of a wildly surging Delta variant. Kids are going back to school. There's no plausible scientific reason to follow them any longer than adults. We have massive levels of experience with adults, and we now have a very large quantity of experience in the childhood population that's being studied. Get these approved now. And I join them in that urging, but right now we are not seeing that happen, unfortunately, anytime soon. I want to end with this audio from one of our employees to kind of give you the frontline view.
The Houston Public Media Newsroom. I'm Gail DeBotter. For hospital workers, a fourth wave of COVID means a fourth time they'll be dealing with not just a surge in cases, but also heartbroken families, seeing their patients die, and the resulting mental health struggles. Health reporter Sarah Willa-Ernst talked to Avery Taylor. She's a head nurse at Houston Methodist Hospital's highly infectious disease unit. She asked Taylor, does it feel different this time around?
The first couple rounds, it was chaotic and frantic, but there was a lot of energy from healthcare providers. We felt like this was really meaningful work that we were doing. These people needed our help. That's not the feeling this time around. This time around feels like we're walking in just to like a cave of needless suffering. These patients don't need to be in hospital beds. We have a magic bullet and we're not taking it.
Are you saying that because the majority of people ending up in the hospital now for COVID are unvaccinated?
Yeah, so that's the really hard part about this is we've recommended everybody in our lives get vaccinated. The statistics don't lie. 98% of patients in Methodist hospitals right now are not vaccinated.
So with you and your team of nurses, what's the general attitude in your unit now?
So general attitude is of frustration. Obviously we got into healthcare to take care of people. We want to help people, but we're having to do some mental gymnastics to really dig down and find our compassion right now. I feel very committed that any patient ends up in our beds, we are going to take care of and take care of well. But I spent Sunday at church just crying through the service, because I'm so sad and I'm so frustrated that there are going to be people who, suffer and die when they don't have to. And I don't know at this point what else to say or how to appeal to people's emotions or their logical brains to change their minds and to get vaccinated. I honestly was in denial, all of last week, even as I've been hiring nurses and opening the second unit, I was thinking, oh, it's just a spike from 4th of July. Surely this is not what we're doing again. And each day the numbers went up and went up. And I guess denial is a great coping mechanism, because I finally realized oh gosh, we're really doing this again.
So what do you do to take care of yourself, and for people in your unit, for people to take care of each other?
Yeah, so this week's been pretty busy. I can't say that I've done a very good job taking care of myself. But overall, a lot of my staff have started going to therapy, including me. And actually, it is not unusual for my staff to say something about well, my therapist says, which I think is great. We're also reading books together. We have a book the title is The Four Agreements. reading that together has calmed a lot of anxiety. It's brought us a lot of peace. Like, it's helped us communicate with each other better. So that's been nice.
Even with all these efforts to, like you said, normalize talking about mental health, and I know Methodist has made mental health care more accessible for y'all, do you feel like it's made a measurable change? Or do you feel like even that's not enough?
I mean, no, like, it's only enough if you use it. But I know my nurses are hurting. I know that I'm hurting. We don't want to do this again. But I also know that, like, we will. But I think my biggest concern is, like, at what cost? And I don't think anybody has answers for that yet. I think only time's going to tell us how many nurses end up leaving the profession. I want to think that it's not going to be anybody, but I'm sure that will end up happening.
That was Houston nurse Avery Taylor speaking with News 88.7's Sarah Willa Ernst.
It's pretty appalling to hear some of that, isn't it? And you just feel for her and her colleagues, a cave of needless suffering that they walk into each day, and talking about, kind of doing the mental gymnastics to bring the compassion to bear to people couldn't be, shouldn't be there, and they will do that, and they are doing that, and I'm so grateful to each and every one of them. But I wanted you to hear the pain in the voice and how hard that is. So you look at this, and I've shown this image many times about the brave men and women, but sadly, I saw this cartoon not long ago, and this is what it feels like. It feels like everybody's pulling against these individuals. So, please help. Please do your part. Get people vaccinated. Do the things in the community that we need to do to get this surge under control. Much as I've asked in the past, we have a frontline appreciation initiative. We would love for you to do that. It's as simple as, it doesn't need to be money. It doesn't need to be a thank you note, a card, other things like that come into our teams mean the world to them. These are exhausted men and women. Dr. Faisal Masood, if you want to read a little bit about this, Wall Street Journal today. Actually, if you Google that, not him, but you Google Wall Street Journal today and about how staff feel, you'll get to that article. He's the photograph in there, and his quote is basically, this is just Groundhog Day, day after day after day. There's a very nice article in one of the critical care journals talking about the need for mental health support for our critical care professionals. This cannot keep going on like this, or people will not be able to do this. So please help. And with that, I'm going to turn things over to Ashley. And Ashley's going to walk us through some of the science and some of the data behind this. Again, I know we're running late, but these are very important topics. We will then get to your question and answer after that. I know Dr. Bernard has also been fast and furiously answering many of those questions. And I think between my talk and Dr. Drew's talk, we've already covered a bunch of them. Thank you so much.
Thank you, Mark. And I would like to start actually by thanking you for all of your leadership. We would not be where we are today without you. So thank you. And thank you all. Wanted to start with talking about the Delta variant. It is the name on everyone's tongue these days. So as you know, it is labeled by WHO by Greek alphabet, and we are to Delta. It was first identified in India, and it has several concerning attributes which make it a variant of concern. It's both in increased transmissibility. It also has the potential to have a reduction in the neutralization by some of the EUA monoclonal antibody treatments, including the one that we previously used, bamlanivimab, has now been removed from the market. Also, potential reduction in neutralization by post-vaccination sera, which is more concerning. And it may be twice as transmissible as previous variants. Next slide. So the Delta variant breakthrough cases may be more transmissible than unvaccinated, transmissible in people who have been vaccinated as people who are unvaccinated. And that is concerning. That's one of the reasons all of us got our vaccine, not only to protect ourselves, but really to prevent us from passing COVID to other people. So breakthrough cases were reported to a national passive surveillance system, and they had lower cycle threshold values by 3 cycles and compared to alpha with the Delta variants. And so that refers to the PCR testing. And basically, whenever you are doing PCR testing, you actually have to amplify the small amount of nucleic acid in the sample. And depending on how much is there, you have to run multiple cycles. And the lower the amount of nucleic acid that you're starting with, the more cycles that you have to run to detect it. So actually, the lower the cycle threshold is, so the less number of cycles that you have to run to detect it, then the higher the viral load is in general that you're starting out with. So lower cycle thresholds mean that it's more viral load there and more infectious. So in Massachusetts, in Barnstable County, they had an outbreak, and they saw that there was actually no difference in the mean cycle threshold values between vaccinated and unvaccinated people with Delta, which is really concerning, showing that they had really exactly the same baseline viral load. So when they look at the Delta variant, we're also concerned, so does that cause more severe infection? Are people at risk for more severe infection if you're infected with Delta? And it seems that possibly that is true. The data is supporting that. In Canada, they show that there was higher odds of hospitalization with an adjusted odds ratio of 2.2 for people who were infected with Delta. ICU admission and death, the adjusted odds ratio was 2.37. So if you had a Delta, you were 2.3 times more likely to die than you were if you had the native wild type variant. In Singapore, they showed people who had Delta variant had a higher odds of oxygen requirement, ICU admission, or death, with the odds ratio at 4.9, so almost 5 times more likely. So really a much more severe infection. And then the pneumonia was not statistically significant. In Scotland, they also showed a higher odds of hospitalization with Delta variant versus the other variants. So does this matter? Which is worse? Is it worse to be more transmissible, or is it worse if it's more lethal? So I wanted to walk you through this. It's math, and so this is a Sussman type slide. So for y'all, since I know everybody's missing him, we'll start at the top. So if you start with a baseline COVID-19 with an RT, so an infectivity rate of 1.5 and mortality of 0.5%. Then you go through 10 transmission cycles, so about 3 months later, you'll see over to the right that you actually have 5,800 infections and 29 deaths. So in the next experiment, you're going to have your same COVID-19 with the same infectivity rate at, with an RT of 1.5, but now it's 50% more lethal. So the mortality rate is up at 0.75. Again, we go through the 10 transmission cycles. So look at 3 months later, and you'll see that you have 5,800 infections, and actually you would have 49 deaths. So compare that to the bottom where you have COVID-19 and you've actually increased the infectivity rate. So now it's 50% more. So your RT is 2.25 instead of the 1.5, but the mortality is down to the 0.5. After your 10 transmission cycles, so 3 months later, look at this because it's exponential. That's what we've been talking about. So you have 332,525 infections and 1,663 deaths. So it's really very important. That's why we focus so much on the R value and why it has such an impact on all the numbers and what we see. So looking at the viral variants and looking at the vaccines, obviously we're all concerned. You know, a lot of us have been vaccinated, and you know, so how is our vaccine going to work, and what happens with Delta, and what is the data? So you'll see for Pfizer on the top against D614G, which was really what we were seeing last spring, 95% efficacy, so really looking good. Then you look at the Alpha variant, also known as the UK variant, and efficacy is still great. It's at 85 to 95%. Looking at the Beta variant, 75 to 100% depending on studies. But look at Delta. It's anywhere between 39%, and that's from Israel, to 88%. And so really, you know, drop off there for Delta with Pfizer. So what about other vaccines? Moderna, you'll see, you know, similar numbers for D614G at 94%, for Alpha 89%. They don't have the same level of data for Beta and Delta, but it's thought to be likely similar to Pfizer based on single dose data. You know, it's a 2-dose vaccine, so we don't have the full similar comparable data, but likely to be similar. For J&J, you know that we're starting out with a slightly lower efficacy even at D614G at 72%, Alpha at 72%, and then at Beta down to 57%, and for Delta 67%. Novavax, which we don't have here yet, but for D614G is 95%, Alpha 89%. For Beta, it's about 60%, and that was an HIV negative population. We don't have any data for Novavax on Delta. And then AstraZeneca is 70% for D614G, 76% for Alpha, and then down to 10%, so really very poor. That's why it was pulled. The studies were pulled in South Africa because of its poor efficacy against that strain, and 60% for Delta. And so what's really important is, as you're hearing, Delta is what we have here. So actually over 90% of our isolates in Houston are Delta at this time. So what we're concerned about and what is important really is the vaccine efficacy for Delta right now. So Pfizer has done a lot of studies looking at their vaccine versus variants, and they're looking in highly vaccinated countries. So when they look at Qatar, and they're looking at the UK variant and also at the South African variant, and they have about 44.5% of the cases were from UK variant, and then our Alpha variant, and then 50% were the Beta variant. And you see the vaccines were very good at preventing infection. For the Alpha variant, 89.5%, and the Beta variant 75%. But really, again, as we've said all along, the major goal is to prevent any severe or critical disease or fatal disease. And so for any form of SARS-CoV-2, it was at 97.4%, and for either Alpha or Beta, it was 100%. So really in Qatar, Pfizer was still performing very well. And this is, as you will know, pre-Delta. In Israel, you'll see earlier on in an Alpha predominant period for preventing asymptomatic infection, it was 91.5% effective. For symptomatic infection, up to 97%. Hospitalization also at 97.2%, and death almost 97%. So really looking very, very good. But here's where things get more concerning. In a Delta predominant period, for prevention of asymptomatic infection, only 39%. For symptomatic infection, a little bit better at 41%, but still very good at preventing hospitalization and severe illness at 88% and 91%. So looking at immunity, so a lot of people have questions. How do I know if I'm immune after my vaccine? And what studies are there out there that we can measure? So there are really this is really simplified, but there are two big categories that we look at when we're looking at immunity. And one is humoral, and that is your antibody response. So antibodies to the receptor binding domain of the viral spike protein are produced after both natural infection and after vaccination. And they're associated with neutralizing activity, and that's associated with protection against reinfection. And we can actually measure these anti-spike antibody levels right here in our Methodist lab. And so it's still unclear. It's not been determined exactly what the cutoff is. And so, people will get their lab result and say, okay, I have a number now, but what does this number mean? And so obviously the higher the number, the better, and the lower, the more likely you're still at risk. But for our lab, people feel that if your titer comes back at 1 to 450 or higher, then it is likely that you have protection. There's no guarantees, but that's a pretty good number. So 1 to 450 or 1 to 1350 and higher, we feel are good numbers. There's also other immunity, T cell or cellular immunity, and that we cannot measure. So there are SARS-CoV-2 specific CD4 and CD8 T cells that are developed in response to natural infection and vaccination. And so you may have these memory T cells and cytotoxic T cells that are there, and hopefully would be called into action if you were re-challenged with the virus, and would help to prevent reinfection and disease. But we do not have ways to measure this in clinical laboratories. So for people who have been vaccinated and don't have antibody titers, all is not lost. They may still have T cell immunity that we are not able to actually measure. So there are questions about, the dosing. Both of the mRNA vaccines, both Pfizer and Moderna, are 2-dose vaccine series. And how important is that second dose? People get the first dose, maybe they don't feel that great. Am I protected? Is that okay? Is one sufficient? And the answer is no, it's not. So we looked at our own data here at Houston Methodist from January to April. So, this is really more in an alpha predominant time. This is before Delta. But you'll see for prevention of hospitalization, one dose was 70% 77% effective, but that second dose got you up to 96%. And prevention of death, it was 64% for the first dose and 99% for the second dose. So really it's important to have that second dose. When we look at a study from the Public Health in England, so they have AstraZeneca there and Pfizer, and so they're looking at their data for both Pfizer and AstraZeneca, and you'll see both for Alpha and for Delta a significant improvement after the second dose for Pfizer and for AstraZeneca, and that is even more important when you're looking at the Delta variant. So here's another question, and Dr. Boom already touched on this a little bit, but what about immunity from natural infection? Certainly I get asked pretty frequently, and it comes to people's minds, so I've been infected already, so do I really need a vaccine? There are people who in the past, mothers used to just put their kids in the room and try to expose them to chickenpox when they're young so they could just get the immunity and be done with it. So can natural infection with COVID do that? Do I really need a vaccine? And will it add anything if I've already had natural infection? And actually, yes, it does. I feel pretty strongly that it does, and that you should be vaccinated even if you've had infection with SARS-CoV-2. So Dr. Boom mentioned this study in Kentucky, but also we know that vaccination appears to further boost the antibody levels in people who have been previously infected with COVID, and so we can measure their antibody levels after infection, and then after vaccination we see that those titers go up, and it's thought that it is likely to improve both the durability of their antibody response and the breadth of protection. Instead of being only protected against the strain that they saw with their natural infection, the vaccination hopefully gives them a more broad response so that they are able to fight off other challenges, other variants and types of COVID that they might see in the future. This case control study in Kentucky that was an MMWR, they took people who were previously infected with SARS-CoV-2. So they had 246 people who had documented infection with SARS-CoV-2 in 2020, and then again in May or June of 2021. So really not too good. You've had it 2 years in a row. They get 492 controls, and they match them by age, sex, date of their initial infection in 2020. And so they looked back, but those controls did not have it again in 2021. And so they looked back to compare their vaccination rates, and they saw that 20% of the case patients versus 34% of the controls were fully vaccinated. And so as you've heard, the risk of reinfection was 2.34 times higher in those that were unvaccinated than those that were fully vaccinated. So really the vaccine added a lot to natural infection. That's pretty early too. That's after they just had infection in 2020, and we're already seeing, in 2021, that benefit. Partial vaccination, so the single, not the two-dose, but the partial vaccination in this study was not statistically significant and did not give them the same level of protection. So that has also been a question that comes up sometimes. If you've actually had natural infection, maybe you just get the one dose, but no, you actually need the full vaccine series also. So, but you did see in this previous study and in other studies, and I know we're all hearing about breakthrough infections, there were those people who actually had COVID in 2020 and they got the vaccine and they still actually get infected again. And so what about that? I wanted to look at that a little bit more. You'll see that in these blue bars are people who are fully vaccinated, and then in green are unvaccinated, and you'll see the huge benefit of vaccination. So for a disease incidence, you'll see there's an 8-fold reduction in incidence of disease in people who are fully vaccinated. So very important. And as we've said all along, the vaccine is even better at preventing severe disease and hospitalization. And you'll see to the right that there is a 25-fold reduction in both of these parameters. So vaccine is very, very important. These are national estimates. But here's something that we're seeing that people are concerned about and want a further explanation. So you'll see going back to January, and this is only through May, so it doesn't show what we're seeing this summer with the Delta. But you'll see in the blue, it's the percentage of people who are in the hospital who are fully vaccinated. And so you'll see the percentage of people who, yes, are deaths. And then in the kind of gold is the people in the hospital who are fully fully vaccinated. And so, back in January, hardly anybody was fully vaccinated. And so you see we're starting low. But as the vaccination program was rolled out across the country, there are, that denominator is getting larger. And we have more people who are fully vaccinated. And so as a result, we will see more people who actually are in the hospital with COVID, who are fully vaccinated. And then the question is, why are we seeing more deaths, throughout the months in people who are fully vaccinated? And I think part of that reflects our vaccination program in general. We rolled out vaccines early to those who were at the highest risk, so frontline healthcare workers, but also to the highly vulnerable people who were at the older and people who were immunocompromised. And so those people, by definition, were at higher risk of death already. And so I think that's why we're seeing it. It's not that the vaccine is failing, it's just by the parameters and our vaccine program. As you've seen by lots of data, the vaccine is really helpful. This is a slide from Dr. Sussman for all of you who are missing him. So according to CDC, and this is back in July 19th, so it's not totally up to date, but at that time there were a total of 4,072 vaccinated Americans who had been hospitalized with symptomatic breakthrough infections. So there is our 4,000, but that's out of 161 million people who had been fully vaccinated. So the breakthrough hospitalization rate is less than 0.003. So you see that's extremely low. And of those people who were hospitalized, only 849 have died of COVID-19. So the death rate from the breakthrough infection was 0.0005. So extremely, extremely low. And the death rate from COVID since 2020 is 1.8%. So that's 3,500 times greater. The death rate from COVID in the week before this was published, so in July, was 0.4%, 800 times greater. And so, as he goes through, he says the chance of dying from lightning strike is 0.007. The chance of dying from seasonal flu is 0.1. So, really, you can compare your odds. So if you're fully vaccinated, your chance of dying from COVID is very, very low. You have a better chance of dying from hornet, wasp, or bee sting, dog attack, car crash, drowning, sunstroke, choking on food than you do from COVID. So it really is good news. Vaccine is a miracle of science and really, really helping us. Sorry, went the wrong direction. But how long are our vaccines going to last, and do we need a booster? I mean, that's really one of the major topics that everybody wants to talk about. So when we look at the vaccine efficacy of the Pfizer vaccine through the first 6 months, you'll see that it was 91% against COVID-19 infection in general, 97% against severe disease, and 100% in South Africa with the Beta variant. So really looked good at 6 months. When we look at Moderna, this is just their press release. It was 93% against COVID-19. So also looking good. When we look here at Pfizer data, and so this is a pretty complicated slide. I want to walk you through it. You'll see that the data on the left, they are looking at wild type and beta variants, and they have two age groups. So they have the 16 to 55, and then they have 65 to 85-year-old. And on the left, you're looking at the sera, their antibody titers before vaccination. So, there are no titers. And then you'll see early on at week 1 after vaccination, and then you'll see the titers start to slowly drop off. And then you'll see robust improvement in the titers after a booster shot. So, and the booster shot is just a third dose of Pfizer. There's nothing, it hasn't been modified or changed. It's the same as the first 2 doses that the patients had received. And you'll see that that was true for both the wild type and beta variants, both in the green and the orange. And what you'll see when you look over to the right for the persons that are 65 to 85 is the same pattern. It's just a lower magnitude. So they mounted a lower antibody response to start out with, but they also had a very nice, robust improvement in their titers when they received that third booster dose. So when we look at the right, we're seeing how things look with Delta, which is really what everybody's interested in. So you see both wild type in green, and then Delta in blue. And again, you'll see this younger age group group in the left and the older age group on the right. And you'll see also that after time, their titers are waning. And with the third dose, you see an increase to both wild type and Delta. And you'll see for the people on the right, particularly for Delta, after in phase 2, before they get their booster dose, their titers have dropped significantly. And so that third dose is beneficial to them, and they did have a nice response. So what about Moderna? You know, obviously there are a lot of people who have had Moderna, and Moderna has been doing some studies, and they actually compared 3 different options. One similar to Pfizer, where they just give a third shot of exactly the same vaccine that they gave for their priming series, so just the same. Then they gave one that they had genetically modified, and it was optimized to be more active for the Beta South African variant. And then they gave one that was a 50-50 mixture, so of the original and the modified. And so before the booster, which was about 6 to 8 months after the prime vaccine series, they saw that 92% still had titers against the D614G, but only 50% had titers that were felt to be sufficient against Beta or Gamma. So, you know, obviously those titers are dropping. After the booster versus the Beta variant, and so they were, this data is using their genetically modified booster that was optimized for that variant. You'll see that the titer went way up to 14,000, and so really looked great. And that's one of the things that's really nice about these mRNA-based vaccines is how quickly they can be modified in response to changes in the virus. So it's a great platform and gives a lot of flexibility for future. So who could benefit from a booster, and who might want one soon and be eligible? So the elderly, as we have seen already, the antibody response is lower just from the prime series. They tend to generate a lower antibody response, and it wanes faster than it does in other persons, and so their antibody levels are lower. They also have more comorbidities and are at higher risk for progression to severe disease if they're infected with SARS-CoV-2. That's the reason that they were prioritized at the very beginning to receive vaccines early, because they have this higher risk. So they are certainly in a risk group, and that's why certain countries are actually rolling out, such as Israel, booster doses to people in the older age group. Also immunocompromised. There's been a lot about immunocompromised and their lack of response to a priming series. So there are multiple studies now that show an inadequate response to vaccination in these groups with risk of infection, severe disease, and even death despite full vaccination. And so we definitely need a strategy for them, and I have more to come on that in just a second. And then there's concern for people who actually completed their vaccine series longer ago. So maybe it's just a little bit of time from your original priming series, and the longer you go from your priming series, maybe your antibody levels are waning, and it may be time for a booster. When we look at the immunocompromised populations, there are multiple different studies that show that they are at risk. You'll see that it was 71% against SARS-CoV-2 infection anywhere between 1 to almost 4 weeks after the second dose of Pfizer for a population that was immunosuppressed, and that included transplant recipients versus 90% overall. For people who were had inflammatory bowel disease and were on immunosuppressive medications, it was about 80% at 7 days or more after the second dose of an mRNA vaccine, 75% against asymptomatic COVID, anywhere between that 1 week to 4 weeks after the second dose of Pfizer for immunosuppressed people, and then 59% against hospitalization at greater than 2 weeks after the second dose versus 91% in people without immune compromise. These are different studies. I will say that we have done a study here at Houston Methodist and our own solid organ transplant recipients, and shown that actually only 30% of them mounted what was felt to be a sufficient antibody response. So as you know, that's extremely low, and very concerning that they remain at risk. So very hopeful for boosters for them very soon. So I mentioned age-dependent neutralization of COVID and the variants. And so you'll see that actually age is very important on your antibody response. You'll see on the left, this is, the baseline antibody response. and in the blue triangles at the bottom. And so you'll see that people before vaccination did not have antibody levels. And then you'll see after vaccination in the gold triangles. And this was interesting to me. You'll see that that actually starts to wane starting at 20. So I guess things are going downhill literally starting at 20 as far as your antibody response. So very early. And so not only is it the level of antibodies, but it's also, we study the antibodies and the ability to neutralize a live virus. And so on the right, they're looking at both the wild virus in blue, and then the P1 or the gamma variant in the gold. And so you'll see that actually neutralization is lower for gamma in general. So the gold is lower than the blue, but same trend where the antibody levels are trending down with age. So you've heard a little bit about what's going on with the boosters. You've seen that other countries are doing it. It's not here quite yet. So Pfizer proposed in July a third dose for those at highest risk, particularly to augment protection against variants. And at that time, FDA and CDC said, not yet. Americans don't need those third doses yet. WHO has actually called for a moratorium. They are asking that no wealthy countries give a third doses until at least the end of September to focus on getting vaccine supplies help all of the countries to get at least 10% of their population vaccinated. And this is not true when I say it's the latest update, because there are later updates since I made this slide. But yes, the FDA has been saying they expect to have a strategy by early September in general about who will get a booster dose and when. And we are hoping for more data on that from their meeting tomorrow. But there's lots of chatter and lots to suggest that we will hear more on the immunocompromised patient population either today or tomorrow, and it just couldn't happen soon enough. So we are ready for that. And wanted to talk a little bit about what's not necessarily so new, but about some of the therapies that we are using for people who have COVID-19. And so we are using monoclonal antibodies. And so we infuse the monoclonal antibodies to people who are not in the hospital, who are confirmed with to be infected with SARS-CoV-2, and they have to have mild to moderate disease. So this is something you do really early to prevent progression to more severe disease and hospitalization. And it's been shown to reduce the risk of hospitalization and death versus placebo from 1% to 3.2%. So it's a 70% relative risk reduction. So really it's significant. Important things are you need to treat within 10 days of symptom onset. Obviously you have to confirm that they actually have COVID. They cannot be on supplemental oxygen for COVID. So actually if they were already on oxygen for an underlying lung disease and that need has not increased with COVID, then you could still give them the monoclonal antibody. And they need to have a high risk factor for progression to severe disease. And you see that that's been loosened up a little bit. So BMI of greater than or equal to 25, chronic kidney disease, diabetes, immunosuppression, pregnant, etc. So if they have one of these things, then we are really trying to get them in for monoclonal antibody therapy, because our goal is to prevent any severe disease and hospitalization. And the next slide will show you really where we've been and how active it has been here at Houston Methodist. So you'll see, previously we were very busy. We had lots of infusions, and then things kind of quieted down over the summer. And fortunately for us, when things quieted down, we thought, well, maybe we should, utilize our resources better, and we don't need all these infusion clinics. And we partnered with Next Level Urgent Care so that they could infuse for us. It was still our patients. We would screen them, but they could actually administer the medication. And that partnership has really served us well because now we are still able to utilize them as things are surging again. And as you see, we are really administering huge doses. And this has been an area of huge success. It's not an area, something that's very easy to administer. And, a lot of institutions have not been, although it's very effective, have not been able to do this because of the difficulty with the infusion and the observation. And it comes at the time when a system is already challenged with patients in the surge. And so something that we are really proud of to have done so well. What's new is we actually have the monoclonal antibody therapy available for prophylaxis also. So vaccination is obviously the best strategy to prevent COVID, but we have some people who are vaccine hesitant or very, very, very reluctant. And there are some people who have poor response to vaccination, such as the immunocompromised persons. And for those people now, they also can have a monoclonal antibody therapy if they've been exposed. And so to help prevent development of COVID at all. And so that is a new development and something that we're really happy to have as well. And I think that's it.
Thank you, Dr. Drews. That was very, very helpful, as always, and thank you for your amazing leadership throughout this. I know you work day in, day out, and she's really leading all those protocols and all the decisions that are made across our institution in terms of treatments, therapies. So I'm going to put her on the spot. I'm going to ask her a question I asked her on the phone. I'm going to act like a reporter. I need a one, or maybe a lawyer. I need a one-word answer. If you were running the FDA, would you approve third doses right now for elderly?
Absolutely.
So I'm on the same page as Dr. Drews. So we're a little frustrated. You probably heard that from me. We are hopeful they will do that much sooner rather than later, and get that ability for those who really do want to protect themselves to be better protected even during this surge. And so hopefully that will be there. The supply in the United States is there, and I know there's WHO comments and things, and I don't disagree with some of what they're saying, but the reality is there's boatloads of vaccine sitting in freezers in the United States right now that is, going bad in multiple places. We never waste any, but because we order what we need, and we're already beginning to order kind of in advance, expecting third doses, etc., coming up here. So we will be there for you if and when that is approved, and we can do that. So we're going to move to questions now. So if y'all have spent your hour and a half you're expecting with us, we got you to the time we said we would. Now we're going to spend about 20 minutes on as many Q&A as we can get to. So you got about 20 more minutes if you're hanging in there with us, and we'll do our best to move quickly through these questions. We've answered many of them, and I know Dr. Bernard's probably answered some on the texting as well, or on the chat as well. So the first question, is kind of the money question, right? Is how do we get more people vaccinated? How do you do this? And I really think this is an all hands on deck situation in terms of doing this. I already spoke about employers and how critically important employers will be. I mean, ultimately they have the trusted relationships, and they have the incentives, disincentives, arm twisting, all kinds of things they can do as an employer. And they have a multitude of reasons as an employer to do this. Their ethical responsibility to protect their own employees, their ethical responsibility to protect their customers, and then a multitude of business reasons running the gamut from, of course, if the economy really is wheels starting to come off again at some point, or feeling the impact. We're seeing airlines, volumes go down again, for example. These are all avoidable, and we could actually have an economy that works and businesses that work. If you're in the restaurant business, you're probably going to start feeling this again, for example. And so there's a multitude of reasons there. And then for many employees, you're paying for the health care. And so there are choices being made now that can result in major bills coming due and many other things. So, obviously get advice of legal counsel and all those, but you play a significant role. But each of us then, the tenor of this question is really, well, what about our friends, our families, our relatives who are reluctant? As a primary care physician, one of the kind of tenets I have, one of the most horrible things people do for themselves and to themselves that I work on every time I see them is smoking. And one of the tenets of primary care is you're not going to convince somebody in one conversation usually, and you're going to bring it up each and every single time that you see somebody. And so, one thing I would do is be really persistent. Another is you're not going to do it by making people feel small, making people feel bad about themselves. You're going to do it by helping them see the reasons to do it for themselves, for others. And so storytelling works much better than data, as much as I tend to show you a lot of data here. The stories. Work with those family. Have them watch the video of the person and the family who is just devastated because they were, reluctant to get a vaccine, and now it turned their entire family's lives upside down, and oftentimes resulted in the loss of a loved one. Use storytelling about that. Let them see how this can be beneficial to them. Tell them how important it is to you that you want them to be protected, and then you wouldn't want something bad to happen to them, and how they can do this for you. Find that myriad of reasons and keep on chipping away at it. Focus on kind of the immediacy of the things that are good about it. People, as I mentioned, have a hard time kind of seeing that long-term kind of piece of this, just keep focusing on it. If you're an employer, also protect people from loss. So, you want to push them to do this. Well, if you do end up with a side effect, or you feel feel like crap the next day and you're out for a few hours, you're not going to lose your hours, for example. You give them some PTO, put incentives in place, do this. I am seeing people, I get lots of people asking me, well, my 25-year-old won't do this. And then, 3 weeks later, I'm often texting with those people, helping get their 25-year-old into a hospital. And it's just is all avoidable. So many strategies. Take a look at a couple of those articles. There's some interesting data, and you can actually find a lot of other suggestions on how to do that. Another question about vaccines, and this was somebody asking, okay, you've heard me, you've heard Dirk, you've heard Dr. Drews, all saying, look, these are safe, there are no side effects, and we've told you very clearly that this kind of question about long-term side effects is not something people need to worry about. And I know I've specifically said, you can comb the literature, you can comb the history of vaccines, you are not going to find long-term side effects from vaccines. They don't exist. These things come in your body, they mount an immune response. If you have some side effects, it's an allergic reaction, it's something where it revs up your immune response and you have a problem. Think of the myocarditis that's happened at low levels and pretty mild. Think of, with J&J, we saw a very, very low number of people, but nonetheless a significant clotting issue. That's probably all related to kind of a short-term immune response. There is no plausible scientific reason with any vaccine for these to cause a long-term effect. These vaccines, yes, are newer technology. I think we collectively as a country and dialogue about these made them sound too new and too sexy in all the articles for a year, because the reality is this is technology that has been developed over decades. It's been used before. It's never been used on this scale. I can tell you, I think it's actually going to bring much better flu shots to bear for us in the future, much better many other vaccines. I think this will be the dominant vaccine technology. Remember, we keep this stuff in a super cold freezer because it is that kind of breakdownable. So once it's in your body, it gives your body the little bit of instructions to make a protein that's very similar to what any other vaccine does, which is basically put a protein in front of your body so that your body makes antibodies, and then it goes away. It's gone. There is no way this can cause long-term side effects. It's just as simple and straightforward as that. If you look at the next question, what are we doing around this booster issue? That's a great question. You've already seen some of the data we're talking about. We're pretty loud out there about saying it's time. We also right now are doing some titer studies on all of those breakthrough infections and hoping to have data, but that will take a little bit of time to aggregate. I'm hoping it becomes moot because we'll see things happen before that in terms of approvals. So then in green here, you'll see the questions that I've assigned over to Dr. Drews. So are we thinking this will be annual, and maybe it'll be easier so you get one jab and it'll be this plus the flu? What do you think?
Yeah, I hope so. And I think there's a lot to suggest that it may be, certainly not this year, but that could happen in the future, and certainly people are looking into that. And one thing that's important to remember for this year is that you could get a booster and your flu shot at exactly the same time. So early on, we had said that you had to separate your COVID vaccine by 14 days from any other vaccine. That's not the case anymore. So you can get your COVID booster, if those are authorized, and your flu shot at the same time. So, this year we'll probably do both. But in the future, hopefully we'll have one shot and take care of everything.
Perfect, thank you. And another question then, okay, we know Delta is way more transmissible now. Does that change all the rules around social distancing, masking, all the things which, as we've seen, aren't actually happening nearly at the rates they were this winter in society, at least in our part of the country?
Yes, unfortunately it does. Nobody wanted to go back to that, and me included. We hoped we were all out of the woods, but we're not. Delta is significantly more transmissible, and there still are so many people who are vulnerable. And so social distancing is important. So when I'm indoors, I'm wearing a mask, and I recommend that others do also. And so that is really recommended, again, is to maintain masking and social distancing until this is over.
Okay, thank you. And some questions then about, practicalities now. Is it safe to get on a plane and travel around? As I mentioned, we're starting to see airline volumes go back down again. If you've been vaccinated, what does this say about, contracting it, which we've talked about? Can you travel to a hot spot? What about family gatherings and those kinds of things? So we really need to reframe our mindset back to the way we thought about things back in the height of the pandemic back in the winter. So if the travel's not really necessary, do you really need to do it? Figure out a virtual way to do it. But if you do need to travel, I will tell you, when I first traveled a few months ago, I was wearing an N95. When I traveled in June, I wore my cloth mask, right? It was a very different time. I'd be wearing an N95 and a face mask or goggles, honestly, if I'm getting on a plane right now, because I know for a fact there's going to be someone else on that plane who's, high risk of having COVID. It's just the reality, given how this is blowing through the unvaccinated population in particular. From a family gathering perspective, that's always been a challenging environment because, of course, once you're in a family gathering, me too, right? Your guard is completely down. You don't mask in family gatherings and everything. At this point, given where things are, I'd create a bubble. So if you are going to get together for a family gathering, it's not hard to get some tests. Even just a rapid test somewhere is better than nothing. A PCR would be best. And before everybody gets together, go get a test, and you have comfort that your probabilities are much lower. Obviously, everybody should be vaccinated. If you have unvaccinated individuals, that's a very different ballgame. Remember, never did the CDC say it was okay to unmask in public settings for the unvaccinated. It's just we all did, and the unvaccinated all did. This was all about vaccinated people in a previous set of rules when we didn't have Delta. And so, be thinking about that. And then very importantly, it's about personal risk tolerance, and the individuals you're interacting with, right? If this is with a bunch of 80, 90-year-old relatives, you probably don't want to do some massive family gathering. A smaller family gathering with a bubble with a bunch of vaccinated individuals is going to be lower risk. Not no risk, but certainly lower risk. And so use your judgment in those kinds of situations. Okay, so I kind of did a little bit of this, but Dr. Drews, talk about this because, one of the painful parts about COVID was, loss of social interaction, and there's many negatives to that. You have a group of vaccinated people, not a large group of vaccinated people. Can you have a gathering? How would you do that safely? What are your thoughts?
Right. I mean, really a lot of it you've already touched on, and it depends on who are those small group of people, because people are coming different, even though they're all vaccinated. How well do you know them? What are their risk behaviors? Are they, wearing masks when they're indoors in, more risky situations? What is their health status of the group? You certainly wouldn't want to do it in an indoor venue if you have somebody who's highly vulnerable. And so really would take all of those things into account. I personally have continued to gather with a very small group of people who I know have safer behaviors in an outdoor setting where we can still spread out, and this air circulation, it feels much safer, and so I take those things into account.
And look, if we can get over this hump, it won't be that long before we can get back to that. But right now, at these kind of worst points of this, really reframing and thinking like we did before. Okay, so let's talk about schools. Some schools I think started today nearby. Obviously, you can't see a day in the press about discussions about this. I've always said I'll stay apolitical and I'll stay data-based. The bottom line is our children under the age of 12 do not have an opportunity to be protected against this virus with a vaccine. Some of them will have had it and have some degree of protection. Our children above 12 have the opportunity just like other people do. I believe every single school should have every single child, every single teacher with all of the same protections they had in place last year. That's masks, that's social distancing, that's all of the things they were doing. I'm not saying go back to virtual. We weren't saying that last fall, ultimately, when we got over the hump either. And I think we showed throughout a surge this winter that can be done, although it's going to be harder with Delta than without Delta. But without masks, you're going to see large outbreaks, most likely, unless we get over this hump really quickly, happening in schools. If you go to the experts, the people who are sworn to protect our children, the AAP, the American Academy of Pediatrics, strongly recommends mandatory masking in schools, that all schools are utilizing masks for their kids and the same protocols they put in place. And just like they've always done, they said, we want kids in school in person, but those things need to be in place. So, obviously not all of you are going to be able to be at a school with your kids that, are going to be in that situation. So I would be thinking then about, well, how am I going to educate my kids, make sure my kids are going to be masked and doing the safe things throughout the day. And of course, the second you can get them vaccinated, I would get them vaccinated. Let me talk a little bit about kids, because I've been asked that sort of on the side from an email last night. What are we seeing? In talking to colleagues at Texas Children's, for instance, They're at the highest level they've ever been on children with COVID in-house. It's not dramatically higher, but it's higher. That looks to be, I think, mostly the transmissibility issue, that this is so transmissible right now, not necessarily a massive severity issue, although that's still TBD. The other thing we have seen, unfortunately, in children is when the masks came off, RSV, or respiratory syncytial virus, which is a virus that particularly affects very young children or immunosuppressed children and can be a very significant and unfortunately sometimes deadly pneumonia. It also affects elderly people, and we've seen some of it in elderly people. It's never present in summer. It doesn't happen, and it's been surging through summer basically because you have kind of those young kids, that first year of life. You now have 2 years of those kids who have never seen it, because most kids do okay with it, and they're seeing a big surge of that. So the pediatric hospitals, unfortunately, are very, very full, and unfortunately, they're starting to see double infections. They're seeing some kids with both of those, and so again, all the more important, let's get this curve broken and let's get people masked. Okay, so let's talk about long COVID. If you've been vaccinated, but you have, unfortunately, one of these either symptomatic or asymptomatic breakthrough infections, what's your risk of long COVID?
So I think that remains to be seen, obviously, because we're still seeing the asymptomatic breakthrough infections now. But in general, it's felt to be much less likely that you would get long COVID, because long COVID we're seeing most commonly in people who had more symptomatic and more severe disease earlier. So your odds of getting long COVID are much lower, and so it's hopeful.
And there have been some reports of people who even had long COVID and did a lot better after vaccination.
Exactly. The vaccine actually helped their long COVID symptoms.
So get vaccinated. It's yet another reason probably that you'll have much less risk of that. One of you asked about kind of essentially herd immunity. So if you do the math on an R of 3-ish, which is where we were before, that was that famous 70% kind of herd immunity level. Now remember, herd immunity can be vaccines, it can be natural immunity, but you have to kind of handicap that based on a 95% effective vaccine or whatever it is, and you have to handicap that based on how effective is natural immunity. So even there you probably need a little higher, but we were approaching that on aggregate. You do the math on an R of 6 or an R of 7, you start getting in the high 80s, 90% range for herd immunity. And then when you start factoring in some, vaccines are probably not 100% kinds of dynamics anymore. The reality is you probably can't quite get there. That doesn't mean you can't get there with this just being back in the baseline and everybody vaccinated and nobody really getting sick and 90+% efficacy against hospitalization and death, and small numbers of those and small numbers of deaths in kind of a normal world. But you're probably not going to achieve that. All the more important, we have to get everybody vaccinated going forward. Okay, so talk about quarantine recommendations now. CDC had come out with multiple revisions over time. Now we've got Delta, you've got breakthrough infections, it's much more infectious. Does it change the game in terms of who quarantines, who isolates, all those kinds of things?
It hasn't changed, at least as far as CDC recommendations on quarantine, but it does change a little bit. So a vaccinated person who is exposed to somebody with COVID, obviously the most important thing is they need to monitor themselves for symptoms. And if they have symptoms, then they would immediately want to quarantine and test. They don't officially, according to CDC, have to quarantine if you've been vaccinated and exposed. With that being said, I would say you certainly wouldn't want to go around anybody who is very vulnerable after you've been exposed for the first 14 days, and you want to be very cautious. Also, you are required to wear a mask when you're around anyone for 14 days after you've been exposed. So there is a level of increased protection that's recommended. And earlier on, they had said a vaccinated person who's been exposed doesn't need to test unless they develop symptoms. Now, because of Delta and because it is so highly transmissible, testing is recommended after exposure, even for vaccinated persons, usually around 7 days.
Assess your own situation,
Yes.
Assess who's vulnerable, how vulnerable you are. Now, I'll tell you, in our family, we had a couple people with a very significant exposure that happened, and we ended up kind of separating over the course of a few days across 2 different locations and got testing, and everybody was fine, thankfully. The vaccines worked, we're all vaccinated, and nobody got it, but it was a pretty significant prolonged exposure. That was our assessment. So I think everybody kind of has to make some of their own assessment with that. okay, what are the symptoms now? If I've been vaccinated, I'm getting a breakthrough. How am I going to know?
Yeah, exactly. And so the symptoms can be very mild. Again, sometimes it's asymptomatic and we're just picking it up with testing. But for a lot of people, they have a very mild disease and they think it may be just allergies or it may feel like the common cold. And so the only way you know is to get tested. And so it's really more important than ever to be tested if you have any symptoms that you think may be associated with COVID. So if you have, stuffy nose, runny nose, some of those GI symptoms, then now would be the time to get tested for COVID, because that's the only way you know if those symptoms are a breakthrough infection or not.
Okay, I'm going to give you a quick answer on this one, which is a question of, you figure out if it's Delta or not from DNA testing. Yes, that's correct. In fact, our DNA testing is actually approved kind of for screening purposes. We actually are not able to tell a clinician or yes, you have Delta or no, you don't. Honestly, it's a moot point. You have COVID, and actually at this point we think it will be Delta, so we'll know on aggregate, but we won't have that diagnostic ability, nor does anybody else, just because those tests aren't approved to do so. But it is through genomic DNA testing that we get there. Question here about, is there any credible sort of rapid test kit that you would recommend, in employer setting, rural setting, some of these here, Dr. Josie?
Right, I saw that question. So I'm spoiled, I'm here at Methodist and I'm very partial to our PCR-based tests, but I understand that is not easy for everybody. And so in rural areas, I checked with Dr. Bernard, and he said that the Binax test he would recommend for this setting. So it has about 84%. So it's not the same as a PCR-based test, but it's pretty good. Mm-hmm.
Okay, great. And I'm going to wrap up with one last question here that I've been asked a couple times. The last one I just skimmed by. I think I answered with the children question before. And this was somebody asking, okay, I've heard hospitals get paid more if somebody has COVID than, let's say, they don't have COVID. And if they die, in this case, if they die from COVID versus pneumonia, I assume what they mean is some non-COVID pneumonia. And the question is there some sort of incentive to report? So first off, the answer is yes. The government put in place two things. One is there is a percentage uptick for patients with COVID versus some other diagnosis. That's government payment at Medicare, which is a rate we lose money on for every single patient versus other types of insurance. And then the second thing they did was they put insurance in for anybody with COVID who's uninsured. So if you're uninsured and show up with a heart attack, we take care of you, and that is charity care. If you're uninsured and show up with COVID, we get paid for that patient with COVID. That being said, with all of that, we have very strict coding rules on what is what with our physicians, with others. I'm 100% confident when we call something COVID, it is COVID, and it is the result of COVID, following those rules, and I'm confident other hospitals are as well. And I can tell you, come walk our halls, if we could safely do that right now, you'd be pretty appalled, because I'm going to walk after door after door after door after door, and you go hit some of our ICUs, you're going to see the rooms full of equipment keeping some of these people alive. It is a very, very difficult time, obviously, for the hospitals, for the people who work here, and for the community and the patients we serve. So with that, I want to thank everybody. I know we went a little long, but we really wanted to get to a very robust discussion, get to your questions that you've been asking, and we really appreciate all of your support. Really appreciate, I hope, that we've rallied everybody to say, okay, we have to do things together as a community, and all of us have to play a role in that within our social networks and within the groups of people we influence. And I thank you for that. Would really thank you for doing anything you can do to support our staff, support our teams, tweets, posts on Facebook, a quick note, whatever it is, they see that, and it just, rallies them up and bolsters their morale, because it is a tough time for them after 18 months and going through this again, particularly, as you heard, going through this again at a time where it's just so painful to watch somebody struggling, oftentimes console families as a loved one dies, knowing it could have been avoided. So with that, please be safe. God bless, and thanks again for all of your support. We'll see you in early September. Thank you.